Hi guys, welcome to the rheumatology module. This is Dr. Patil here, and the first module we will be discussing the approach to rheumatological disorders, or in simple words, musculoskeletal disorders. Now, when it comes to rheumatological disorders, one thing is very important, a proper pattern recognition. So when you gather information from the patients, when you get the history, when you know that patients presented with joint pains, whether small joints are affected or large joints are affected, whether the onset was insidious or acute, whether we are talking about an acute arthritic condition or whether we are talking about chronic condition, whether patient is having inflammatory joint disorder or whether he is having non-inflammatory or degenerative joint disorders, right? All this information put together, a pattern emerges, and this pattern recognition leads us to the diagnosis. So the whole effort of today's exercise will be behind the pattern recognition. Okay. Now, when we talk about pattern recognition, the first thing that should come to our mind is pain. Pain is the most common complaint that patients would present with to a hospital, right? So pain is the most common complaint. And when patients present with joint pain, it need not always mean that there is inflammation, right? There are a lot of conditions where there is joint pain as a complaint present, but there is no objective evidence of the joint inflammation. For example, if I talk about hypothyroidism, many of these patients do complain of joint pain, but there is no objective evidence of inflammation. Similarly, during viral infections, I'm not talking about the post-viral arthritis that some of the patients experience. I'm generally talking about when we are going through acute or febrile illnesses, we might have joint pain. Okay, again, I'm not talking about certain post-infectious arthritis. I'm only talking about general acute febrile illnesses where joint pains are common complaints. There also we may not find any objective evidence of inflammation. So in all these conditions, we call it as just mere arthralgia. Then how do we differentiate patient's pain, whether it is mere arthralgia, whether it is due to mere arthralgia or whether it is because of arthritis, right? So important potential pointers towards the inflammatory changes or arthritis is presence of joint swelling. If patient complains of joint pain and if there is joint swelling, obviously that means it is arthritis. Similarly, if there is joint tenderness, so most arthralgic conditions, there will not be joint tenderness. Okay. The third point is whether there is redness present. Redness, not usually seen in all circumstances, but certain acute presenting conditions like gout, you might have the evidence of redness of the affected joints. Even in the absence of the redness, if there is joint tenderness present and joint swelling present, that goes in favor of arthritis. Okay, here we have to also differentiate between the pure joint involvement where there is synovial involvement. In that case, there will be a fusiform swelling of the joint, right? If this is the joint, there will be a fusiform swelling of the joint. So if you're talking about the hand swellings, then you will have a fusiform swelling around the joint. On the other hand, we have to also differentiate it from something called as dactylitis, where there is a diffuse involvement of the digit or diffuse involvement of the finger. No fusiform swelling, the whole finger is involved. Then we call it as dactylitis, as we see in patients with systemic sclerosis, or we might see in patients with psoriatic arthritis. We might see in patients with sickle cell anemia also. So that is also something we should be aware about. Okay, so now we know differentiation between arthralgia and arthritis. Next comes the question. Okay, now you're having a patient who is having joint pain, and we know that it is a proper joint pain, means it is not arthralgia, it is arthritis. But there also, again, it may not be proper articular joint pain. The pain also may be originating from extra articular structure. So we have tendons, we have the tendon insertion site called enthesis. All of them may be part of or solely be involved in causing pain, right? So how do we differentiate between the pain that is originating from articular structures or synovium or the pain that is originating from extra articular structures? So the first point to ask patient is whether you feel the pain is deep seated or superficial. So articular pain is usually deep seated, very often diffuse. Patients cannot pinpoint one location of pain. It is deep seated and diffuse. Okay, then the second thing we notice is articular pain usually gets worse on both passive as well as active movement. Passive and active movement. On the other hand, extra-articular pain is usually superficial because the structures are superficial, right? And patients might have a specific area of distribution of the tenderness. For example, there may be linear tenderness if patient is having tendinitis. Patient may have point tenderness if patient is having enthesitis, right? And then the particular last point I wanted to tell you is this pain, which is superficial, may be associated with the linear or point tenderness, the pain is usually worse only on active movement. The passive movement usually doesn't worsen or trigger the pain in this case. The reason is very simple. You are having tendons or the insertion site. Those sites are contracting when we are doing an active movement. When we make a passive movement, there is no tendon contraction involved. There is no contraction of the muscle involved, right? So when we do a passive movement, the antagonistic muscles are usually relaxed. It is not brought about by the active contraction of the primary muscles, right? So because of that, the tendons are not moved, and thus the pain is not perceived or not worsened, right? Okay, so this helps us to distinguish between the articular and extra-articular joint pain. Now comes the real question. Now, once you know that you have a patient presenting with real arthritic condition, most often you will have articular, like for example, if I'm talking about rheumatoid arthritis. So you will have tendinitis, you will have enthesitis, you will have synovitis. So that distinction is only important when you want to differentiate between the articular involvement versus the pure soft tissue disorders. But otherwise, most of the systemic rheumatological disorders, there is both articular as well as the extra-articular structures being involved. Once you know that this is an arthritic condition and not mere arthralgia, so once you know that this is a proper arthritic condition and not mere arthralgia, then comes the question of pattern recognition, right? So let us first talk about the duration of joint pain, because part of the pattern recognition is to classify the cases as acute or chronic. So in case of rheumatological disorders, we will call it as acute when it is present for less than 6 weeks, and when it is present for more than 6 weeks, we will call it as chronic. I hope that is clear, right? So if you remember the classification criteria for rheumatoid arthritis, if it is more than 6 weeks, we are giving 1 point because rheumatoid arthritis is a chronic disorder, right? Okay. So we know the duration. Now next, I think according to me, the most important thing is to differentiate between inflammatory versus non-inflammatory joint diseases. Yes, we are dealing with arthritic condition, but some of them are because of the inflammatory changes and some of them are because of the non-inflammatory, for example, degenerative changes. A classical example of inflammatory would be rheumatoid arthritis, or maybe even SLE related or systemic sclerosis related arthritis. And when it comes to non-inflammatory, I think I would be strongly thinking of a very classical example for non-inflammatory is osteoarthritis, which is a degenerative joint disorder, right? How do we differentiate between these two clinically as well as based on the laboratory evaluation? So for that, mainly we are concentrating on two things: pain as the complaint, and second thing is early morning stiffness. Okay, so patients with inflammatory joint disorders usually have pain which is worse on rest, and movement puts little bit of ease to them, right? So patients with rheumatoid arthritis, usually they have rest pain, and when they are moving around, the pain is slightly better. So their pain is worse after prolonged inactivity, and when they start moving, right, when they start moving, they start feeling little better. And on the other hand, the non-inflammatory joint disorders, as I have already told you, osteoarthritis is our classical example. The pain here is worse on movement, worse on movement. So these patients generally feel better on rest, and when you ask them to move about, their pain gets worsened, right? So again, you can say that the patients with inflammatory joint disorders, they have their worst mornings and their better evenings, because morning there is prolonged rest, they have taken the rest in the night, so morning they experience severe pain, and as the day progresses, the pain starts easing out. On the other hand, non-inflammatory joint disorders, after rest they are better, so their mornings are refreshing, and as the day starts progressing, they start experiencing worst kind of pain. Okay, so that is with respect to pain. The second point to note is what we call as early morning stiffness. So patients with inflammatory joint disorder generally have early morning stiffness, though it can be seen in non-inflammatory. The duration is something that we should be paying attention to. So in inflammatory joint disorders, the early morning stiffness usually lasts for more than 60 minutes. At least for diagnosis, we need 30 minutes plus, but in most cases, it lasts for more than 60 minutes. On the other hand, in the non-inflammatory joint pain, there may be early morning stiffness, but it is always less than 30 minutes, right? So it is usually less than 30 minutes. Okay, there may be additional pointers to think this as an inflammatory joint disorder if the patient is having constitutional symptoms or extra-articular manifestations, because we're talking about all these rheumatoid arthritis or SLE. These are all systemic disorders, right? So patients may have other systemic manifestations. That also is a potential pointer. On the other hand, if you're talking about osteoarthritis, it is purely a disorder of the joints. It's not a systemic disorder, so you may not have any constitutional symptoms or systemic manifestations. So fever, malaise and all are very typical of inflammatory joint pains, not usually seen in patients with non-inflammatory joint pains. And when you examine these joints, right, you will notice that swelling is very common in inflammatory joint pains, because the inflammatory joint pains are primarily because of the synovial inflammation. On the other hand, non-inflammatory swelling is unusual if present, particularly osteoarthritis is where you're likely to see. If present, it will be bony. It will be bony swelling. On the other hand, it will be a soft swelling when we talk about inflammatory joint pain, because it is originating from the synovium, right? Okay, then when you examine for tenderness, the tenderness in case of inflammatory joint pain is diffuse. It is diffuse over the joint space. But in case of non-inflammatory, it is present on the joint line, right? This is again one important point. Tenderness here is present on the joint line in case of non-inflammatory. Inflammatory, it is diffuse. Okay. Then having signs of inflammation are quite common. Obviously, redness and all, usually not seen when patient is in a chronic phase, but when there is acute flare-up, or when you're talking about some acute inflammatory joint conditions like gout, you will have clear-cut evidence of inflammation in the form of redness and warmth, right? So you will have redness and warmth, which is obviously not seen in patients with non-inflammatory joint disorders. Okay, then non-inflammatory joint disorders can sometimes cause instability of the joint, which is usually not seen in inflammatory joint disorders, though in the chronic phases of rheumatoid arthritis, there may be significant mutilation and instability can be seen. Okay. Systemic involvement, as we all know, it's very common in inflammatory and it is uncommon in patients with non-inflammatory, right? So these features help us to distinguish between the inflammatory joint pain and non-inflammatory joint pain. Two important take-home points. One is pain, whether it is worse on movement or whether it is worse on rest. Pain worse on rest is inflammatory, pain worse on movement is non-inflammatory. Early morning stiffness is the second important point. Early morning stiffness more than 60 minutes, very classical of inflammatory. At least 30 plus is what we need. Less than 30 minutes, more in favor of non-inflammatory joint pain, right? Okay, so I hope that is clear. Now let us address the next point, that is the number of joints involved. So we have these classical terms, right? Monoarthritis, oligoarthritis, and polyarthritis. So when we call it as mono, obviously when one joint is involved, we call it as mono, and we will call it as oligoarthritis when there is involvement of 2 to 4 joints, right? When there is involvement of 2 to 4 joints, we call it as oligoarthritis, and when there are more than 4 joints involved, that means 5 or more than 5 joints involved, we will call it as polyarthritis, right? A very classical example of monoarthritis, I think the first thing that comes to my mind is acute gout, acute tophaceous gout. Then the second thing that comes to my mind is septic arthritis, and then the traumatic arthritis. So gout and septic arthritis are two things I want you to remember. When we talk about oligoarthritis, I think only thing I want you to remember is spondyloarthritis. So oligoarthritis is the hallmark of all the spondyloarthritis conditions, right? Okay. When we talk about poly, we have a long list of disorders. So that includes rheumatoid arthritis, that includes SLE related arthritis, that includes systemic sclerosis related arthritis, that includes even one exception to this spondyloarthritis, that is psoriatic arthritis, which can be polyarthritis, right? Then you have this nodular osteoarthritis, where there is predominant hand joints involvement, small joint involvement. Osteoarthritis can affect large joints like knee joint, where it is usually oligoarthritic condition, or it can predominantly affect the small joints of the hand. Then we call it as nodular variant of osteoarthritis, which is obviously a polyarthritic condition, right? Okay, so now we know when we call it as acute, when we call it as oligo, poly, and mono. Now let us also talk about the mode of onset, acute versus insidious. So when we talk acute, I think we should be remembering, I'm talking about the mode of onset, not about the duration. So duration acute means less than 6 weeks, chronic means more than 6 weeks. So in terms of onset, acute classical examples are gout. Then the second thing is reactive arthritis, which can also present as acute. Then septic arthritis can also present as acute, right? So these are all things that should be coming to our mind. Most other chronic conditions are usually insidious in onset. So for example, rheumatoid or SLE or osteoarthritis, these are all insidious in onset. Okay, so that is about the mode of onset. Next comes the symmetry. Okay, so when it comes to symmetry, again, it is something that we should all be well aware about. Asymmetry is the hallmark of spondyloarthritic conditions. Spondyloarthritis. So all the disorders that are grouped under the heading of spondyloarthritis asymmetry is the norm. So if it is symmetric presentation, you should be looking for alternative diagnosis. On the other hand, most other conditions that I'm talking about, like rheumatoid arthritis, SLE, or even the osteoarthritis of the hand, may be symmetric, right? They may be symmetric. In fact, asymmetry in rheumatoid arthritis or SLE maybe should prompt you to think of alternate diagnosis. Yeah, another thing which is usually asymmetric is gout. Gout also is obviously going to cause asymmetric joint involvement, right? Okay. Now, the distribution of joints is also particularly important because some joint disorders predominantly affect the upper limb, some joint disorders predominantly affect the lower limb, and if you know that, then pattern recognition becomes a little more easy. So rheumatoid arthritis, psoriatic arthritis, and nodular osteoarthritis, these are the disorders where there is upper limb predominant, but remember, all these conditions can also affect the lower limb joints. Okay, I'm not saying that these are exclusive upper limb joint disorders, but there is upper limb predominant involvement in comparison to lower limb. On the other hand, spondyloarthritis. So spondyloarthritis, it is like a rule of exceptions. So it is a oligoarthritic condition. It is a condition where we were talking about in the previous slide, right? The asymmetry is the usual rule. Similarly, spondyloarthritis usually affects the lower limb joints more than upper limb. All the conditions that come under that, exception being psoriatic arthritis. So psoriatic arthritis predominantly, as we have already discussed, affects the upper limb more than lower limb. Otherwise, most of the conditions that are listed under spondyloarthritis and gout, both of them have a predilection to affect lower limbs more than upper limb joints, right? Okay. Then there is last disorder, that is hemochromatosis, which predominantly, or it's almost known to affect only upper limb joints. So second and third metacarpophalangeal joint involvement is very characteristic of hemochromatosis. Second and third metacarpophalangeal joint involvement. So this is one which predominantly affects the upper limb. Here both are affected, but slightly more predilection for the upper limb, rheumatoid arthritis, psoriatic arthritis, and nodular osteoarthritis. Spondyloarthritis and gout, the lower limb is more affected than the upper limb. Okay. Now coming to the types of the joint affected. So some disorders predominantly affect the small joints and some predominantly affect the large joints. So again, our rule of exception comes here. So large joint predominant involvement should make you think of spondyloarthritis. Okay. All those conditions, except again an exception being psoriatic arthritis. Otherwise, all the conditions that are listed under the spondyloarthritis, starting from ankylosing spondylosis to reactive arthritis, most of them predominantly affect the large joints. On the other hand, there are a lot of disorders which predominantly affect the small joints, being rheumatoid arthritis, nodular osteoarthritis. The non-nodular osteoarthritis, which generally affects the weight-bearing joints, that obviously is going to affect the large joints, right? But the nodular osteoarthritis, obviously being the disorder affecting the small joints of the hand in the form of nodules, affects obviously small joints, right? Okay, nodular osteoarthritis, SLE related osteoarthritis, and then psoriatic arthritis. Those psoriatic arthritis grouped under spondyloarthritis. So spondyloarthritis itself is an exception, and among that, again, psoriatic arthritis becomes an exception and starts behaving more like the other joint disorders. So here there is predominant small joint involvement, right? Okay. Now, certain specific joint involvement may be a very important potential clue for the diagnosis, not only for the clinical practice, but also on MCQ. So whenever I say that there is involvement of DIP, that means something, right? So when it comes to DIP involvement, DIP is usually spared in patients with rheumatoid arthritis, and DIP involvement is involved characteristically in patients with psoriatic arthritis. Two conditions should come to your mind: osteoarthritis and psoriatic arthritis, right? Okay. So when we talk about distal joint involvement, this DIP involvement, we are talking about psoriatic arthritis and osteoarthritis. Then the involvement of first carpometacarpal joint, here, right, at the base of the thumb. This involvement is very characteristic of patients suffering from osteoarthritis. So this is very characteristic of osteoarthritis. And then we were talking about hemochromatosis in the previous slide, right? So involvement of second and third metacarpophalangeal joint is very typical of hemochromatosis. Right? So DIP is usually spared in patients with rheumatoid arthritis. DIP involvement is very characteristic of psoriatic arthritis and osteoarthritis. Then involvement of the first carpometacarpal joints is very typical of osteoarthritis, and the second and third metacarpophalangeal joints is very typical of hemochromatosis. Okay, so these are important potential MCQ points, and this can be directly asked as an MCQ. Which joint is more predominantly affected in hemochromatosis, or which joint show the earliest changes? So when I say predominantly affected, that also means earliest changes are also seen in the same set of joints, second and third MCP. Okay, then comes the question of the sequence of joint involvement, because some conditions there may be intermittent joint involvement, in some conditions it may be migratory, and in some conditions it may be additive. First, let me address the intermittent joint involvement. When we talk about intermittent joint involvement, that means there is frequent episodes of aggravation and or flare-ups and remission. Then we will be calling it as intermittent, right? So the first thing that should come to our mind when patient presents with intermittent joint involvement is obviously gout. Other than that, patients with reactive arthritis may also present with intermittent joint involvement, right? On the other hand, the differentiation between migratory and additive is something that we should be very much aware about, because in both these cases there is sequential joint involvement, right? Then what differentiates migratory from additive? When I say migratory, that means the patient, let me say that first joint that was involved was wrist joint. So patient has made substantial recovery, or he is near normal recovery at the time when the next joint is involved. When the third joint gets involved, he has recovered from both first and second joint involvement. So there is sequential involvement with the previous joint making near total recovery when the next joint is affected. Then we call it as migratory. A classical example for migratory is rheumatic fever. We are all aware about it, right? Rheumatic fever. But then you should also remember, apart from rheumatic fever, even the Lyme borreliosis can also present with similar picture, right? Lyme borreliosis or Lyme disease can also have migratory polyarthritis, right? Okay. Then when we say additive, that means you have sequential involvement of joints, but the previously affected joints are continuing to progress. They have not made recovery when the next joint gets affected, right? A classical example for that is rheumatoid arthritis or osteoarthritis or SLE related arthritis. In all these cases, there is one joint involved, right? Then when the second joint is involved, the first joint is still active and it is progressing. When I say active, that means the degenerative process in case of osteoarthritis or inflammatory process in case of rheumatoid arthritis, that is active. So the joint is still affected, it is not recovered, it is progressing, then the next joint gets affected. When the third joint gets affected, but first and second joints are still progressing. That is what we call as additive, right? Okay, so now we know the difference between intermittent, migratory and additive, and we also know the causes. So this summarizes all the key points we should know to do a proper pattern recognition. So with this information, when you start learning about all the rheumatological disorders, be it spondyloarthritis, rheumatoid arthritis or osteoarthritis, it starts making a lot sense. Okay, now before we wind up for the day, let us also spend some time on understanding synovial fluid analysis, so that when we discuss the synovial fluid findings in the core videos, it will be a little easier for you. So when we look at synovial fluid analysis, the fluid analysis pattern can be grouped into 4, but particularly for a physician, we are interested in differentiation between inflammatory and non-inflammatory synovial fluid changes, right? So for that, we are mainly looking at two things: viscosity of the fluid, and second thing we are looking at is cell count. See, apart from that, synovial fluid analysis will give a lot more information. For example, if it is gout, so you will be seeing those crystals. If it is septic arthritis, you will be able to get the fluid for culture. Those are secondary. My goal here is to discuss differentiation between the inflammatory and non-inflammatory. So when we collect the synovial fluid, the pattern can be either type 1 where it is suggestive of non-inflammatory, or it could be type 2 where it is suggestive of inflammatory, or type 3 where it is suggestive of septic, or type 4 which is hemorrhagic. That hemorrhagic could be traumatic aspiration as well as the real hemorrhage into the joint space. Okay, first let me address this hemorrhagic. Whenever you have the synovial fluid analysis report, if the RBCs are more than WBCs, in all probability it is a hemorrhagic tap or it is a hemorrhagic synovitis, right? So in that case, mostly it is related to trauma or some extreme degenerative disorder, a proper orthopedics territory. Septic arthritis, yeah, every now and then we as physicians might encounter patients presenting with septic arthritis, so we should be aware. The fluid would look very purulent and it may be opaque. And then when you look at the cell count, the cell counts are extremely high. In most cases, 60,000 plus. You might not be surprised when it is 1 lakh plus also, right? There is a significantly high, very high WBC count predominantly comprising of polymorphonuclear cells, right? So neutrophil count is usually more than 80%. Okay, and obviously you can gram stain for the presence of bacteria. When you look at the inflammatory synovial fluid, it might have some degree of cloudy appearance. Okay, but when you look at the cells, you will see 2000 to 75. The cells can be elevated here also, but it is usually not as high as you see in patients with septic arthritis. 2000 to 75,000 may be there. 50% plus will be polymorphonuclear cells. And when you compare it to the non-inflammatory type 1 synovial fluid picture, the cell count is usually less than 2000. So this 2000 is our bar here. 2000 plus we will be considering inflammatory. Less than 2000 we will be considering non-inflammatory. And if you look at the differential count, more than 50% in case of inflammatory will be polymorphonuclear counts, and this percentage might rise whenever there is acute flare-up. Okay. On the other hand, in non-inflammatory cases, the PMN count will be less than 25%. That is second point. The third and equally interesting point is looking at the viscosity. We have something called as string sign, right? So viscosity in the non-inflammatory conditions is extremely high because of the loss of hyaluronic acid. This hyaluronic acid is the one that is reducing the viscosity and giving a proper lubricating experience between the joint surfaces. So these non-inflammatory conditions often have loss of hyaluronic acid, and that increases the viscosity. So that leads to something called as string sign. So what is string sign? When you take the synovial fluid in a syringe and you drop it, it usually forms a string when the viscosity is high. So this high viscosity, the string that is formed will easily stretch up to 5 centimeters. So it will stretch usually more than 5 centimeters. So when it is stretching for more than 5 centimeters, you can say there is high viscosity and the string sign is positive. When it is breaking before that, when it is not able to stretch for 5 centimeters, when it is breaking before that, that means the viscosity is low. So this low viscosity is typical of inflammatory, septic, and to some extent hemorrhagic arthritis. So in case of hemorrhagic, septic, and inflammatory arthritis, the viscosity is low, mainly because of the presence of inflammatory markers that reduces the viscosity, and then you will not have the string sign. So the string may be formed, but it will not last for 5 centimeters. It will break before that. If it is lasting for more than 5 centimeters, then that is typical of non-inflammatory or type 1 synovial picture. Right? Okay. So that kind of summarizes all the things that we need. I would wish you all the best for your learning the rheumatology. Please go through the subsequent videos, and if you find anything difficult or which is controversial, and my approach or my colleague Dr. Dilip or anybody's approach is something that is not in accordance with the current practice or standard, you can definitely communicate with us, and we will be discussing or debating those topics on our Prep Ladders premium Facebook page. Thank you all.